I think we
I
can.
mean, I still think we need to have the Zoom capability at that meeting for people, not in the local area so that they can still participate from everywhere, right?
Yeah.
Because I think it's, especially people who have a long commute, it's probably not, it's probably good to have that, and our technology should be good enough that they can really participate.
Yeah.
As if they were in person.
Diego, let's talk about what's ideal, an ideal balance of in person and remote. I agree, we've got the technology. I mean, I know that it's, and I think a lot of members of the AHP team will agree, it's never ideal when some people are in the room together and some people aren't. I feel like the people who aren't are at a real disadvantage, and it's but let's keep working at it.
Right. But even if we have, I think that one room we met, there was a big screen TV, so those people could be on a big screen, right? And they can speak up during the meeting. I mean, we can try it once. If it fails miserably, we can go back to this format.
Okay. Let me work with our assistants to see what availability is. I haven't reserved a room for a meeting, and I don't know how long. And that one, the room you're talking about, it used to be in high demand. So let me see what the availability is, and I'll follow up with you.
Okay, sounds good. Steve, you agree with that?
Absolutely. I also think, we've started going back to some in-person meetings, but I think we just want to be sensitive. There may be people who aren't super comfortable. So
right.
It's another reason to keep offering the Zoom even for people.
Right. Right. And I think with Zoom, it's better than sort of like that phone thing that we had in the inception of this meeting, which is just, you were somewhere in the dark cloud above us. But now with the visual, you can see us, we can have a discussion. I think it's, a good way of participating.
No, absolutely. I think we're.
Oh, the real deal. Look, the real deal is participating. Elijah, how you doing, buddy?
Let me say hi. Hello.
Elijah. Just about ready to get going, Diego. I do want to comment because I just saw Dr. Mary Lou Gleason come into the room. Dr. Gleason works at South Wedge Internal Medicine over at Highland Hospital, and she is joining our committee. South Wedge Internal Medicine had been represented by Dr. Markakis, but between the two of them, Mary Lou and Kathy, they've decided to pass the baton to Mary Lou. So thank you, Dr. Gleason, for joining our group. We're looking forward to working with you.
Thank you for having me.
Okay, that's it for the Renee stuff, Diego, if you want to.
Okay, that's the only announcement?
Yep.
Perfect. Well, welcome everybody to the Adult Primary Care Advisory Committee. Got a lot of things on our agenda today. I think we're going to lead it off with Dr. Fu, who's going to do a little presentation on the outpatient psychiatric consultation opportunities. Dr. Fu?
We're going to have Dr. Nasra make a brief introduction, though, before she gets started. And Dr.
Gotcha.
Fu, do you want me to share your presentation, or are you all set to do that when the time comes?
I should be all set. Thanks,
Okay.
Renee.
All right, thanks. Sorry, George,
Okay,
go ahead.
no problem. Thank you. Thanks, Diego. It's my pleasure to welcome and introduce Dr. Fu. Dr. Fu is Annabelle is a psychiatrist at the University Medical Center. She is the medical director of our ambulatory clinic, which basically is the name for our largest psychiatric outpatient clinic in the department. She's here to make us all aware of a resource in the department that allows you to refer patients for psychiatric evaluation and medication recommendations. And now, before I turn it to Dr. Fu, I want to make you aware again that the AHP website under the behavioral health tab has also several resources for you as well. This is where you can find the depression screening toolkit and several very short, couple-minute long training videos on depression screening, self-management, and psychopharm. We also encourage you to send us an email. There's an email for the BHI team. It's ahpbhi@urmc.rochester.edu. So that email can be used by any provider, including nurses, including any clinician in your practice, to ask questions, clinical questions about patients, and we try to respond within 24 to 48 hours to that email. Now, one thing the BHI team cannot do is to schedule an appointment to actually evaluate and see your patient. And this is where Annabelle and her team can be helpful. So Annabelle?
Yes, thanks, George and Renee, for inviting me tonight. Just a little bit more about my background. I actually have been here since medical school. So I graduated residency in 2015 and decided to stick around. Hopefully we've kind of interacted on various levels during my time here, but I'm primarily outpatient, as George mentioned, mostly outpatient mental health, but also sometime in our strong ties and strong recovery clinics. So one of the places I am part of is our outpatient psychiatric consultation team, which some of you may have heard of or utilize, and this might be new information. So I just wanted to get the word out there. Let me share my screen here. Okay. Everyone see that okay? All right. Okay. So I'll just go over a little bit about who we are, what we do, where we're located, when and how do we make a referral to us, and then why we do what we do. So feel free to unmute and ask questions, and I'll do my best to check the chat, but I might need some help there. So who are we? Our team consists of a combination of psychiatrists along with a robust nursing team. And then we do have psychiatry residents and medical students that rotate with us. You might see some of our familiar faces. Dr. Tyler Fleming joined us a couple of months ago. Dr. Roma Fortuna has been around for many years doing consultations with primary care. I do a little bit of time also with the team the last year or two. Dr. Gonen also does some consultations with us along with other responsibilities that he's part of. And then Dr. Jeff Eiler also has many consultation responsibilities, including our outpatient service here. So, and some of our prior psychiatrists include Dr. Mike Privatera, Dr. Sam Camp. So you might have interacted with them on some level. So. And then our nursing team often collaborates with the primary care team. So you might also see their names coming by. Hillary Harder, Heather McGroarty, Mary Jo Newcomb, and Luke Paddock. So, okay, what do we do and don't do? So these visits are sort of these one-visit psychiatric consults, which usually lasts about an hour. During that hour, we really do a pretty thorough sort of, history taking in terms of mental health and your current symptoms, what folks are looking for in terms of both their referral from the referring clinician and from the patients themselves. Part of our evaluation does include sort of this diagnostic evaluation about what we think might be going on, and then treatment recommendations based on our diagnostic evaluation. So we focus on adult patients only, and although this is a one-visit psychiatric consult, we welcome you to re-refer them if you've kind of considered all the recommendations and want some further input. Because these are consultations, we do not offer sort of ongoing medication management. We specialize in mood disorders, so these are sort of the depression, anxiety, bipolar disorder, along with OCD, PTSD, and some less common psychiatric diagnoses. Really, the main thing is that the patient must have a primary care provider or a specialist who is currently prescribing and is willing to continue prescribing psychotropics and consider sort of our recommendations. That's probably the number one requirement. And then number two is that the patient must reside in New York State, or at least be located in New York State during the time of the appointment. So. Things that maybe we might consider other resources to utilize rather than first line utilizing our psychiatric consults. So this might include patients who have a significant substance use disorder and would benefit from a specialty clinic addressing that. Folks who are specifically requesting evaluations for ADHD or autism. Although we are happy to help sort of manage symptoms that might be related to these diagnoses. But for patients who are specifically looking for that evaluation, we do have a list of community providers that we can provide to assist in doing those evaluations. And that goes along the same thing with the psychological testing. If they have a little bit more complex mental health disorders, such as psychosis or psychotic disorders, we might recommend to refer to like an ongoing mental health service. If they actually have an ongoing psychiatrist, nurse, or nurse practitioner that's working with them, we're happy to offer second opinions. We just ask that the consult request does come directly from the person who's prescribing for them. And if patients are looking for therapy only, or maybe sort of a clinic-based therapy plus medication management, we are happy to kind of provide resources in terms of referring to mental health services in the community. Any questions so far about this?
One quick question.
Yes.
You said you referred to it as a 1-episode consultation. I distinctly remember that this was a 2-episode consultation. Can you just speak to that? That's a little different.
Yes, that is a change, and I'm glad you brought it up. So we have uniformly moved towards a 1-visit consult model in an attempt to essentially cut down on our wait times. So we'll talk about that in the next slide, but we were booking out 3 to 4 months with sort of these multiple consultation visits. And we've actually are currently down to our goal of getting folks in within 2 weeks. Now, because of that, even though it's a 1 visit, because we're able to get folks quickly, we are happy to kind of see them again within a very reasonable time frame in that fashion. So
Thank you.
you're welcome. So a little bit about where we're located. So physically, we're located at 2 locations. One is within the city next to sort of the Eastman School of Music, 150 North Chestnut Street. Some of you might remember we used to be located at the main hospital. And then the other location is over at Pittsford. But either location and all the providers offer telehealth or televideo options. So we definitely want to have that flexibility for you and for the patients. So how do we go about referring to us? So, when is the right time to refer? When you're really not quite sure what you're treating and you want a little bit more input in terms of, the mental health diagnoses, or when you've tried a couple of first line recommendations and things aren't just improving or going the right direction. So I just want a little bit more input. If you're within URMC, we do have an e-record referral system, which I listed there through the order system. And I know our ordering system is not always the easiest. So I tried to kind of put out very straightforward how to do so. But you're also welcome, you or the patient are also welcome to give us a call. Our nursing team is very knowledgeable in terms of navigating all these little e-record things and our mental health system. So feel free to give us a call at any point. Now, if you're outside of a URMC system, no problem. Again, our phone number, you can give us a call, either the referring clinician or your staff or the patient themselves. You can also fax a request, and a request as in sort of sending over your most recent medical note stating sort of why you are referring for a med consult and sort of a list of medication that they are currently on. And ideally, you also, if you're able to include sort of past trials and other pertinent information, that would be helpful for our consultations visits. So after we receive the referral, our nursing team will provide outreach in terms of a phone screen to the patient. They will also reach out to the referring provider to confirm some collateral and prescribing. And then they'll go ahead and schedule the patient. And as I mentioned, our goal is really to get patients seen within 2 weeks. And we are currently reaching our goals. So feel free to please utilize our service. After we're seeing, usually within a couple of days, the consultation notes should be sent back through e-record or through fax. If you do not receive it, feel free to, again, give us a call and we'll happy to collaborate on that. Questions about the referral process at all? All right. So last but not least, I recently saw this article title, And just kind of a reminder that we are very aware that primary care is in the front line of our mental health crises and addressing a lot of the mental health concerns. And we just really want to be here to support you and make things as streamlined and optimized as possible. So if any questions come up, feel free to, again, give us a call. We do have a website that we're working on improving. We also have if you're within your MC, we do have a e-record in basket. If you have any questions about the workflows or running into any issues, feel free to reach out through us through the in basket, or feel free to email me directly.
So there is a question in the chat asking, noting that your presentation referenced lists of community providers. So where can those be found?
Yes, I would say just give us a call, and our nursing has those lists, and they periodically will call the community providers and make sure that the lists are updated. So just give us a call. We're happy to forward you that information. Anything else or other questions? Or George?
I just wanted to ask you, Annabelle, can you speak a little bit to when you say referring to outside providers? So if a primary care provider has a patient sent to the team for evaluation, is it fair to say that if on a case-by-case basis, if it's identified that this person is in need of psychotherapy or ongoing medication management or referral, that there is sometimes the potential, depending on openings, that we will assist them in accessing that service as well?
Yes, oftentimes we meet folks who really would benefit from some ongoing psychotherapy or medication management. And part of our consultation service is sort of navigating what they're open to, maybe in terms of maybe what's closest to their home, especially based on sort of their mental health diagnoses or mental health history. And so we can kind of help direct patients in terms of what might be the best fit and what might be the most available. So we do our best. I know that our system is backed up, and so we at least try to offer some reprieve in the meantime. So
thank you.
Wonderful. Well, thank you again, and I'll touch base with Renee so that everybody can have my contact information. So
thank you very much, Dr. Fu. I think the important part here also is those lists of providers, because I think that, as Dr. Nasser mentioned, that, the process of finding therapists or people to help the ongoing part of this is very important. That's where sometimes our resources fall short. And I think it's very good that you can provide a guideline of how we can treat the patient, at least ongoing with medication suggestions you have. And I would encourage you to have that sort of re-referral process, in case the medications are failing, so that we have some degree of access to have free-flowing information for patient care.
absolutely, I'll keep that in mind.
I would also just commend you for improving the access through the ways you're talking about, because at a time where across the medical center access is really problematic, it's really refreshing to see a group making strides like this. So really, thank you.
Thank you for that feedback. I'll be sure to spread it to the team.
Great. Any further questions? If not, we'll move on with Daryl Sharp and talk a little bit about trauma-informed care initiative.
Hello, everybody. And LJ Shipley is my partner in this work. And so LJ and I are going to share experience of a pilot program that has been funded through the Health Equity Program Support Office at the Medical Center, the HEPSO office. And it's titled Advancing Health Equity Through Trauma-Informed Primary Care. And just basically what we set out to do, and that we're about 19 months into the project. We'll finish at the end of June. So we're going to give you an update on where we are. So if we go to the next slide, LJ. There we go. What we set out to do was really to advance health equity by supporting 5 practices in delivering trauma-informed primary care. And we really wanted to evaluate the impact of that work. So we used a particular model that we'll share with you, with the idea that at the end of the project, we would use the lessons learned to inform wider dissemination of trauma-informed work as appropriate. So that's really the goal. And we are going to fly through these slides really, and we will make the slides available to you all, but we really want to spend some time talking with you about your ideas about this work. So we want to leave plenty of time for that. So trauma-informed care is really, what is it really? It's really referring to a culture of care delivery that is really seeking to help staff realize, recognize, and respond to the widespread impact of trauma with patients and across not only patients, but staff as well, and to avoid re-traumatization. There's been a lot of work in this space on the behavioral health side for a long time and in our school systems as well. The 6 principles of trauma-informed care include making sure care spaces are safe physically and psychologically, making sure that patients feel that they can trust the staff and the organization where they receive care and they know what to expect. Peer support really refers to patient involvement and having patient voice and informing care delivery, like patient advisory boards. Care delivery that's characterized by a sense of collaboration and mutuality. A lot of trauma involves power differentials, so looking for ways to minimize power discrepancies between staff and patients, and even amongst the staff, the team itself. Going hand in hand with that is this idea of really speaking to patients' strengths. It's not just about trauma people have experienced, but how have they managed that trauma, and what are their resilience factors, giving them opportunities to weigh in, have voice and choice in their treatment. And then also looking to erase biases and stereotypes based on cultural, historical, and gender issues. So those are the key principles of the trauma-informed care environment. LJ is going to tell you a little bit more about what we specifically set out to do.
Yeah, thanks, Daryl. And I think the thing that I would just add in this space is when I think about a trauma-informed approach, and many of you may have heard this phrase before, but it takes you out of the realm of looking at someone in front of you, whether it's a patient, whether it's a parent, whether it's a fellow coworker, a colleague, and takes you away from saying, what's wrong with you? And that kind of an attitude when you're being faced with something that may be difficult, to the phase of thinking, what happened to you? And it just changes, it activates empathy, it activates curiosity, and it just changes the whole conversation. So when we started with this project, I'm trying to get my slides to advance. There we go. We wanted to lift this pilot across different types of practices. And so you'll see that we engaged 5 different HP URMC practices. There's a couple of practices that are large and teach residents, Golisano Children's Hospital pediatric practice and strong internal medicine. There's one FQHC family medicine practice, his branches. And then we engaged 2 different independent pediatric practices, one that's more rural in Stony Brook Pediatrics down in Dansville, and then Long Pond Pediatrics as well. And so we wanted to have both pediatric, adult, family medicine represented in this space while we did this work together. And essentially this has become a learning collaborative with monthly meetings that include representatives from both the clinical and administrative teams of the practice, and that's been really essential. I think we've learned that all along in our work with your practices, right? If you engage only the physicians and not the rest of the team, or you only engage the administrative team and staff, you don't have the same result as when you engage an interprofessional team in this work. And so we've developed action plans for advancing some site-specific practice. So you'll hear about that in the next slides. And then we've piloted this. And then the other piece in this that Daryl's going to talk about a little bit later is we wanted to assure we were thinking about rigor with this. What was the evaluation that we were going to do that would allow us to see if we were having the impact we wanted to have, and actually also identify impact from this initiative that we might not have expected. Though I have to say that piece surprised me. You'll hear more about that later. And obviously we're at this phase with this of then thinking about what are the dissemination guidelines to deploy across the network. And that's where your feedback is going to be really important to us in the second half of our session with you. We really want your thoughts. So be thinking as you're hearing about this, how could this apply to your practice setting? What questions do you have? What interests do you have? What worries would you have? And so to talk about the Learning Collaborative, just in terms of what we structured, we partnered with CCSI. CCSI is an amazing, long-standing community resource with significant connections to mental health and behavioral health at the state level in terms of OMH. But the thing about CCSI that was particularly exciting to us is that they had already lifted trauma-informed care approaches across our community, and most specifically in the schools. Almost all school districts have worked with them. And so when we're thinking about a model that goes from, pediatrics through adult, we want to assure that we're speaking the same language where people are, whether they're in the hospital setting, in primary care, or whether they're in the community. And for kids, of course, that's school. And so you'll see the educational sessions. You can read this in terms of what the topics were that we chose to go with CCSI. And in addition to these educational sessions, there have been monthly peer calls where a team from AHP and CCSI meets with the practices, with their interprofessional teams, and thinking about problem-solving barriers, being able to share successes and strategies. And that's been the richness of this model. I think it's really kind of a reflective practice and support group for doing the work. We've all learned a lot from each other in that space. And so then what's come out of this are these bullets here. So the actual practice initiated trauma-informed care interventions have been great. We abided by the principle in this space that we wanted to go where the practices felt that there was relevance, where they felt that they could start something, and where they felt there was priority. So in all honesty, almost all of the practices at the beginning were saying, I don't know if we can do anything, because we lifted this in the middle of the pandemic. We lifted this during the time that the staffing shortages were going on, when people were sort of at their breaking point in many ways in practice. But they kept coming. And we said, it's okay. You don't have to do anything. Let's think about things that support and nourish your team. What can be done in that space? And so you'll see some of the things that are on here, like the second bullet, establishing regularly scheduled reflective practice and debriefing discussions. That wasn't necessarily part of our original curriculum, but that came to fruition in so many of the practices and in what they were developing. And then there were all sorts of other things that happened as they were working with traumatized patients who were, I think, you've all lived this, more short-tempered, less patient, frustrated with the healthcare system. It's been really hard on staff and on our providers. And so things like de-escalation training for staff who are on the phones, implicit bias and anti-racism training, all of these things, phone management strategies became part of what was done. And anything on this list that is asterisk are things that are planned for implementation in this year, but the practices have initiated these as priority areas and then working with our teams to do that. So that gives you just a little flavor of the work that we've been doing. Daryl, I don't know if you would add to that at all, but I can advance the slides and let you do the next step.
I think the main thing is that we applied a trauma-informed approach to project management with this grant. And that's made a lot of difference, I think, really important. So this is the model that we used. Montefiore is credited with this model. They were part of a collaborative that was sponsored through the Robert Wood Johnson Foundation that was looking at how to advance trauma-informed care in primary care. And we used this, basically the interventions that we wanted to focus on were workforce training. And that's the thing about workforce training is that oftentimes in the trauma space, clinicians are trained, practice teams are trained, but the administrative teams are not trained. So it's really important to have both the administrative and the clinical teams in the workforce training. A focus on workforce wellness, including making sure people are taking breaks, making sure there are workflows in place, if there are triggering events, those kinds of things. Changes to the environment, paying attention to the aesthetic of the environment, things like noise, light, how safe do people feel? Can people get out of exam rooms easily? Those kinds of things. And this model essentially says, to the extent that practices focus on those three interventions, that will impact practice delivery. It will influence the way in which patients and staff interact. It will also influence the extent to which we're paying attention to screening for trauma in the practices. To the extent that we do a good job with that, it will enhance patient engagement and satisfaction. And over the long haul, whatever you do to enhance patient engagement and satisfaction should be an investment in patient health outcomes. One of the things about this model that I thought was interesting is that they made the point that people oftentimes go right to the chase. They go right to the patient outcomes. They want to see the change there immediately. And they were taught, what they talked about in this work was, it's really important also to pay attention to those mediators. If you start to move the needle on these other variables, you're doing something really helpful for practice and care delivery. The model includes two moderating variables to the extent that practices have access to integrated behavioral health resources, either in the form of our BHI team, or some of the practices have psychologists or social workers on the team. Practices have access to care managers with lots of expertise in behavioral health. That will help you implement the model, and then the same with quality improvement resources. So that's the model that we mapped. We used what's called the trust tool, which is not my favorite tool in the world, but it's a tool. And it's used widely across New York State in the trauma space. And it allowed us to assess these variables, as you see listed there, and they map directly onto that model. We collected baseline data on these variables. These are all staff perceptions. So the staff, administrative and clinical teams were surveyed in October 21, and then we did a follow-up survey just last fall. And then we're going to do focus groups to complement the quantitative data. In terms of the quantitative findings, this, again, this is a program evaluation. So we can't say for sure that this project caused this, but all the lines are pointing in the right direction here. So we saw improvement from time 1 to time 2 on training and workforce development, and then also in the area of staff wellness. And that made sense to us because, as LJ mentioned, that's where people wanted to spend most of their efforts. So these were the places where we saw the greatest change. And so the next one, we saw some change in physical environment, some change in screening. Screening is kind of sort of tricky. There's a lot of debate in the literature about whether or not we should be screening for ACEs at the individual level versus using it as a population health tool. So, but we did see some increases in screening and a lot of interest in the practices in that space. And then in perceived engagement and involvement of patients. So we didn't directly survey patients. These are staff perceptions of things like power differentials. How involved are patients in their treatment? Do patients have a voice in the practice, that kind of thing. So we saw improvements in all of those areas. Just additional findings, I guess the thing that LJ and I are not going to go through all of these, but the things that really stuck out to us, all the practices, and there was so much variation in the practices in terms of the kinds of practices they were. Even in the midst of a pandemic, every practice made improvements, and some more than others. And so LJ, you want to take it next?
Yeah, and I think on this slide, the only other one that I'll highlight here is, we've already said it, but it bears repeating. The greatest changes we saw were on staff wellness and training and the workforce development. And this was at a time where many practices were losing so many staff and people were leaving. We were seeing more engagement and more of a sense of belonging and satisfaction in the teams
Mhm.
that were participating in this work. So we felt that was pretty significant considering the time.
Mhm. And then because we looked at we have the data by practice, but these data that we presented today were, of course, across all the practices, which gave us a large enough N that we could do a little bit more diving into the data. We did see some differences in terms of our BIPOC respondents reported lower scores of practice progress in perceptions of safety in the practice environments. And we also saw that staff that were not in leadership positions scored lower than the leaders did. So the leaders perceived the practice environment to be safer than staff that were not in leadership positions, which so we are going to continue to look at these findings and figure out, okay, how might we respond to some of these things? But that's just to highlight some of the equity concerns that surfaced.
And this is technically our last slide, and then we really want to engage you with a couple of questions. But on this is really where we're going right now, and then next steps beyond June of 2023. But where we're going right now, Daryl already talked about, doing focus group data collection and continuing some of the work that we're doing. We really are looking to finalize a toolkit. We recognize that to make this something for dissemination, there's resources. You can see some of the trauma-informed primary care video series that we already have now that our practices have looked at and made recommendations for editing. They're piloting them in their practices to see how they work. But one of the key things we've recognized is this is not a plug and play model. This is no way that this can just be dropped in and say, good luck, this is trauma-informed care and you got it. We have to have some kind of facilitation. There has to be some mechanism for reflective practice for the teams to actually do this work and integrate the work. Thanks, Daryl. And so we've had the opportunity to present to a couple of other groups because there's been interest from other groups. So the URMC Quality and Safety Committee, Thompson Medical Group, AHP's URMC's embedded pharmacy team. It's fascinating and it's exciting that there are so many groups within our health systems that are really interested in doing this work. And we're seeking feedback, talking about the pilot now before we're getting to the end so that this group and our pediatric advisory group has the opportunity to weigh in and make recommendations for what the dissemination could look like. So that is where we wanted to just sort of end our part of the presentation. And then we just wanted to put a few questions up in front of you. So just thinking if you have a minute to reflect on, maybe you're already engaged in trauma-informed work in your practice. That's really important to know. What about this pilot might be interesting to you? What could make this doable within your own practices? And just other questions or comments. And I'm going to stop share because I haven't seen your faces. I've only been seeing Daryl's. So there we go. So reflections.
What do you think about this?
You're already doing. Does this seem like it could be valuable? Steve, you unmuted. I'm calling on you first.
Certainly valuable. It's a little hard for me to fathom how it looks pretty intensive. It's a little hard for me to envision how you roll that out, for example, across 45 practices. I can certainly see the value. Somewhat selfishly, I see that number you showed around staff wellness and the improvement in that score. And it would be interesting. Obviously, you can't draw the correlation, but one would think that could correlate with staff retention. And that's such a huge issue for all of us right now. And so I even think if there were pieces of this that could be done, if you could understand which pieces of the program lead to more staff wellness, if we could even focus there. Part of me wonders if it has to do with the fact that, our staff may be just as likely to have experienced a lot of the trauma that the patients have. They may be actually benefiting from this curriculum in a way that that others of us may not benefit. Let's be honest. So I just think that's really interesting. So if there's a way to maybe just do a subset of the program, if we really knew what the staff were getting, really appreciating that might be really valuable. And
to that point, Steve, at least one of our practices has spent nearly all of their efforts in that space across the project. So not everybody's doing all of it, because not everybody's positioned to do it all. And, you know, it was in the middle of the pandemic, and there is literature about staff retention and trauma-informed care. So there is cost savings in that space. And of course, quality of life, which is more important than the cost savings in my view, but certainly, you know.
I would add on to what Steve said. I would say that in our practice, one of the things that we did during the pandemic was we had daily staff meetings with everybody, and we sort of briefed them on what the state of New York was, what the state of Rochester was, what the state of the practice was, and we were very transparent. And we, you know, kind of went along with that on for several months. And slowly, as everything developed, those slowly disappeared over time. And lately, people have been clamoring for those to come back. So that was something that really brought everybody together. And I see that model in what you were talking about there. And I think that if we learned anything in our practice, is that the more you keep everybody on the same page, informed and understanding what, hey, what's bothering me, or what is my, you know, stressor, and I've seen your stressor and I can help you with that, builds that team effort. And we've been very successful at maintaining that. I mean, we still need to try to include a little more meetings that they want, but it really has come back. And so I think it's been a very good way to kind of follow with what you presented. I don't think we had any of that true model that you had, but little pieces are what we've done. And so I think Steve said, if we can take little pieces here of our experiences, I think everyone can gain from that.
Yeah.
Totally agree.
Valerie.
Yep, I was going to also just echo, I mean, I completely agree with what Steve just said. I think that one of the problems is we have staff that are completely stretched to the point of just failure. I mean, they're working at their absolute limit. And in fact, when we talk about anything to them, they're like, oh, no, not one more thing. It's remarkable to me on days that staff are feeling good, they laugh at the patients, they make them feel comfortable, they make them feel safe. The front staff, they smile at patients. If they're having a bad day, the patients, you know, so-and-so is not nice to me on the phone, or that nurse kind of frowned at me. It's all about, I mean, I shouldn't say it's all about it. So much of that is having our staff feel good, feel nurtured, feels, you know, and then the problem right now is that we're so short on staff. And when we have patients that are traumatized and coming from a place of pain and frustration, and they're hot on the phone, you know, it's so wonderful to have resources like having a psychologist or having a social worker or having someone with a little bit of extra training handle the hot call first, because there's a lot of damage control we do when we finally get the call referred to us half an hour later, and the patient's upset and they want to talk to the manager. And, you know, if we had just kind of, if it could have been de-escalated right up front, and with the people having the right tools or the right ability to reroute people, I would love to have more support for staff. It's hard though, because it's just, we really want to start by giving people more support and not ask them to do more. Otherwise it's going to feel like one more ask at people who say, I can't do one more thing.
That's right. That's right.
I appreciate that very much, Valerie. And I'm seeing Phil Meeker's message in the chat about definitely seeing the benefit of this program, including de-escalation training and staff retention satisfaction, but the time investment seems daunting. So one thing to remember is this was the group that was pulled into the pilot to actually develop the curriculum and pilot all these different things and kind of take it in different ways. So I think one of the things we're hearing from you all is resonating with what we've been thinking, is that we need some compartmentalized modules, but that aren't just, again, a plug and play. There's something with it that includes connection to the staff and facilitation and a little bit of additional support. So we'll definitely take that feedback back as we engage in these next few months, where we're really thinking about winding up the pilot and expanding. Daryl, do you have other comments?
I just want to shout out to Bob Adams and Katie Deal, who have been part of the pharmacy team that have been working with Zipporah Rosenberg and myself. And really we're learning through the pharmacy team, how do we implement a reflective practice process for the pharmacy team that's sustainable over time. So many thanks to Bob and Katie for your interest and participation. We're learning from you.
Yeah, and what I can say too is kind of being a consumer of it, from post-pilot phase is that, Daryl and LJ and their team have really done a good job of kind of tailoring it to the embedded pharmacist needs and really didn't make it feel like just adding on another thing. I feel like it's almost like a different animal in the sense that the team is really like drawn to this and really looking for this because it's something that, from a pharmacist perspective, we never really had any training on this kind of aspect. And, with the pharmacists having direct patient care now in this space, it's really helping equip them. And they wanted more meetings. They asked, we originally set this up as just 2 or 3 kind of sessions to introduce the concept. And they asked, can we have more of these? And so Daryl's been able to tailor that into Spore as well. So it's been a really positive thing for the team.
We are, oh, sorry,
George.
George. Go ahead.
I just wanted to add one thing that this is really an incremental process. That this project, the nice thing about it and the way it's designed is that a practice can decide to implement some of it or a lot of it, depending on what they feel they are able to accomplish. So the slide that Daryl showed with all those different levels, they are incremental. So changing the environment and providing a safe environment and a welcoming environment is one aspect, and doing just that can result in significant improvement. Talking about trauma-informed care and making space to discuss that at the practice, even on a quarterly basis, is still a one step towards trauma-informed care. I often, and Daryl heard me say that, I often make the equivalency with infectious disease, right? So trauma-informed care is a prevention. It's different from trauma-specific care. So when we get into identifying a problem and having a psychologist and how do we deal with trauma, that's different. That's along a continuum, but different from trauma-informed care, where the equivalency with infectious disease is a universal precautions. So we don't wait until we identify a patient who has an infection to wash our hands. We universally wash our hands. We universally make our environment safe for people with infections. And that's the idea behind trauma-informed care, is that we want to make sure that we treat our patients as if they have a history of trauma, because we don't know. They don't come with a label.
Thank you, George.
Thank you for the extra time.
Yes, thank you.
We now cede
Yeah.
to Chad. Are you
Sorry.
next? I think.
You.
I was going to say, you don't get to thank people from time when you just rudely take it from other people on the agenda.
Well,
Now I have trauma because Daryl and LJ stole my time on the agenda. I just want to be
We
clear.
did
That's the wrong time to tell you only have 30 seconds.
Exactly, yeah.
You
Now
did so nicely, though.
I need someone to administer this trust tool to me because I have no trust in my coworkers that they will observe the timing of the agenda any longer. So I'm going to try to be brief on mine. So we have talked in multiple venues on the Wednesday call. We've had it in network news. I think we may have even showed it at the last PCP advisory, that our 2023 quality metric grid is unchanged from 2022. So there are no new metrics. There are, oh, and Renee's putting it up. I was going to say I could put it up now if you'd like, but Renee beat me to the punch. So the grid is exactly what you saw last year. Obviously, the achievement thresholds for 25th, 50th, 75th, 90th do change slightly year to year. There is still work to do in these metrics, but largely they are unchanged from what we were working on last year. That was intentional, as we've talked about here before. Our intention is to pick a core set that we think are high value preventive care efforts that support either our population health risk management, opportunities for general clinical improvement, or support some of our cost spending initiatives, and not to have significant sway year to year. So I think by continuing to work towards that same group, we are largely able to achieve that. I will also say there are some of these metrics that we tend to historically do very well on. Colorectal cancer screening, breast cancer screening being an example. However, coming out of the pandemic, where screening modalities did not get the same attention that they did pre-pandemic, and appropriately so. We're now starting to face where patients are falling back into the gap denominator because it's been more than 10 years since they had their colonoscopy, or they're due or overdue for their mammography. So we do have some work to do really across the board in each one of these metrics, but it's not a whole lift of new metrics as we've had in years past. There are some, what I call the test drive metrics that are behind the scenes that we'll be looking at, working on, potentially kind of strategizing that could come to the grid in years future. The payers generally across the board do like to have a carrot dangled where we're not just always working on the same things, but have kind of progressive effort to constant quality improvement. So we'll be looking at those. We'll bring those back and share with you as they become necessary, or as we think that they may come more mainstream or need conversation. Steve, you've got a Bart Simpson hand raised.
Yeah, just just real quick. So that's the I'm being a little concrete here. That's the Excellus list.
That is what I will call the performance pay for reporting or pay for performance measures with Excellus.
So we just went through a whole thing in the PCN where the HEDIS measure for colorectal cancer has been updated to go down to age 45.
Correct.
That is not happening with the contract.
So actually the measure definition, I think, has not gone to 45 this year. If I remember. Oh, has it, Willie? Did I lie? Okay, so I lied. It did go to 45 this year.
It has, and Excellus didn't update it on their own contract documents, and we're going through to fix it on all of ours because we try to just use what they send us, assuming it's correct. But we do have to update it. Thanks for that catch, Steve.
Okay, all right, thanks.
The other thing that I will mention, and I think we've talked about this in years past, in each year there is a HEDIS, which is kind of the metric domain, if you will. And NCQA, which is the national group that sets the HEDIS metrics, they open a comment period based on their recommendations for what they're intending for the next measurement year. So for measurement year 2024, that comment period is now open. Anyone can go on the NCQA website and leave comments based upon the feedback that NCQA is suggesting for what they're intending for measurement year 24. I will tell you, we've reviewed this internally. Most of the changes I think are actually favorable to us. I will tell you all of the metrics that they are anticipating retiring are not metrics that we have or have had on our grid, so it has no bearing on us at the moment. The changes to the existing metrics, the biggest changes are going to be in the diabetic metrics. So in years past, if you had the diagnosis of diabetes or were prescribed a diabetic medication, you were on the hook for the A1C, for the diabetic eye, and the like. Obviously, in the day and age of using some of the diabetic meds for heart failure management, for weight loss, the prescription for diabetic meds no longer is an absolute indicator of the diagnosis of diabetes. So now you either have the performance revision that they're suggesting is either 2 documented problem list indicators of diabetes, or 1 problem list indicator of diabetes and 1 prescription for a diabetic med. So at some point you will have to list in a problem list that the patient's diabetic for them to fall in the denominator. So that's actually an improvement for us going forward. So I don't think that's something that we would have any argument about. The next piece and I don't think this has a wide application in the diabetic measures for us, but for patients who have continuous glucose monitoring, some of the devices have what they call a CGI, continuous glucose indicator, which is basically a surrogate for hemoglobin A1C. So you can use that CGI measure as an indicator for A1C less than 8 for the diabetic control measures. I think that applies to a very small minority of our patient population. I don't particularly have a concern about that. It would just be another measure of control. But obviously it would have to be integrated and reported in the medical record for that to be able to be queried and usable as an alternative to A1C. The final piece, which I don't think will really affect us is historically for the diabetic measures, there have been two alternatives, either EHR kind of derived information or manual query and reporting from the payer plan of diabetic control. They are in 2024 suggesting to get away from the manual reporting so that it will only be codified data out of the EMR effectively. That really doesn't apply to us. We have not done a manual reporting method, at least in my years at AHP. So I don't think that has any real bearing on us or our reporting or control efforts. So for the diabetic measures, no concerns from my standpoint. The next big one, which I have a small amount of concern, is that for many of the preventive health metrics, including cervical cancer screening, breast cancer screening, colorectal cancer screening, they are going to start including stratification based on race and ethnicity. So basically implementing socioeconomic status into some of these, or I should say social determinants, into some of these metrics. We've known that's coming. They have not said that there will be a different threshold based upon race or ethnicity, more of that there will be a requirement of reporting for the payer plans. My only concern is that if you look across our EHR universe within AHP, there are many of the EHRs that are a bit more rudimentary in their ability to track social determinants of health. And race and ethnicity are one area that many of the EHRs do not do well. And in fact, 2 of our 11 EHRs will default to Caucasian if you don't enter any race or ethnicity information. So we would get credit for reporting, but clearly I don't like the idea of a default race reporting. So it doesn't appear that there's going to be any implication for performance standards, but it is an effort across the board to start reporting on the social determinants. And so I don't have a problem with it. It's just I have a bit of a concern that the EHRs are not up to speed yet across the board. But I do think many of these EHRs will either have to up their game or will be phased out for some of the larger EHR systems, which could have implications for some of our smaller practices. Other than that, there were really none of the other things that I had any clinical concerns about. So normally we would encourage anybody, if they wanted to lobby NCQA for or against, feel free, you still can, you don't have to take my word for it. But I think generally this year, I actually have, for the first time maybe ever in my term at AHP, I have no qualms with any of the changes that they're suggesting for measurement year 24. Now, don't trust anything I say, but in general, it's okay. And I think that's really all. If anyone would like the NCQA link to go and review and give feedback, we're certainly happy to share that with you. We generally do kind of do our own feedback on behalf of AHP so that there is at least our voice is there. But for this one, I think it's largely congruent with what we would like to see.
We'll include it in the meeting summary email that goes out with after the meeting to everyone.
Yes. All right. And unlike my peers, I will cede back 1 minute of time.
Thank you, Chad. We'll put that in your little pocket here that will keep you for next time. So the next topic on the agenda is something that I think we'll all hold dear to heart, which is talking a little about how HP as well as this committee can probably help enhance our experience as primary care. As we all know, we're all overtaxed and we've got prior authorizations and referrals and all sorts of different little pieces that affect our practice and have burdened us and have increased our bureaucracy, and some of it increased our need for extra staff. And so LJ has really put together a advocacy group to look at maybe having a conversation with the payers about trying to figure out ways to improve both reimbursement and let's call it quality of life of primary care in the community. And maybe LJ, you could speak a little bit to this.
Yeah, thanks, Diego. It's really credit to the whole team at AHP. I just want to say, it's all of the people who are represented here, as well as those who are not here from our team.
we are completely aware of how difficult it is to practice primary care now. And, you know, it's a total financial mismatch for so many reasons. And I think that, I'll just say it, like, there's no value-based payment if we don't have primary care. So you guys are central, all of you, and the work that you do, all of our practice teams are so central to the mission of what we are trying to do. That's how we improve quality, right? That's how we improve the health of our population. And so as a group, we have been talking about what are the strategies, what are the ways that AHP can actually help in this space. And so, you know, one aspect of this is, and I think it's a big aspect, is to make the case to our local insurers of just how dire this is. And I'm going to speak for a minute as someone who was in independent practice for a long time. And it is difficult for everyone to practice primary care, but for our independent practices, you know, this financial equation is becoming just worse and worse and worse. And so being able to articulate to Excelis initially as the big player, but to other insurers as well, you know, what that mismatch is. So we know that there are more patients on Medicaid. We know that Medicaid reimbursement is not on par with commercial. We also know that fee-for-service rates, I can say in the pediatric space in particular, but I think in adult too, have just been held flat for so long. And yet the expenses of our practices, your overhead has gone up. It's probably doubled, if not more, because of expenses around all of the things that we have to do all day, particularly around staffing, to have competitive salaries and reimbursement for fringe benefits, just to pay for health insurance for your staff teams, right? Like, it doesn't make any sense, and it is becoming worse and worse. And I think honestly, and we see in the pediatric space that the skimming off of acute visits that are kind of the way you actually make the bread and butter of practice, skimming off of acute visits because of urgent care, telehealth, that sort of stuff is very, very complicating. So for all of those reasons, we are collecting some information from a representative group of practices in the adult space, as well as in pediatric space. And then beginning conversations with Excelis to, you know, we will summarize the financial case, and then we will meet with them to make the point, you know, as it is really, really critical that we preserve the primary care, high quality network that we have. And there are other spaces we can work on too, right? Prior authorizations, you mentioned, Diego, you know, there's other spaces. So it's not just one thing that we're looking at, but honestly, if we don't look at this piece, not having to do prior auths is not going to make the biggest change. So I don't know where this is going to go, but I think it's important that you all know that we are open to your experience and your feedback, and we really are invested in you all.
Thank you, LJ. And what I would say to anybody on this committee is, if you have any data, if you have any suggestions, if you have any ideas, please feel free to email me, email Renee, LJ, and we'll certainly, you know, put it as part of the package that we're going to try to put together to make our case, you know, going forward. I think all of us know, you know, recruiting new partners, recruiting new people in our space is very difficult as well currently in the independent space. So this, again, potentially could open the door maybe to make that easier for us as well, you know, to look for those changes. So please, everybody, reach out. If you have something that you feel would be beneficial, please send it to us. We'll be happy to listen to it.
It's a quick question here from Valerie here. One thing that I'm worried about right now because of the COVID pandemic, where, you know, there's a coverage of video visits. And I'm very worried what's going to happen either in May or 150 days after May, because the insurance companies have allowed that to continue. It's one of the ways that we've been able to practice without staff, to be frank. I mean, I can see videos in the morning, I can see them in the afternoon when I have no staff, when the office is sort of otherwise closed. If we don't have that, it's going to be disastrous to our practices and our ability to take on the patient volume that we've been handling So I wondered how much we're looking at that and addressing that as a group here.
I can probably take that one. We've had that conversation pretty extensively with the payers. So two things that I think are likely to happen. Number one, although they are not willing to outright commit that there will be no change and that we'll have long-term parity, they have largely tipped their hat that there's likely to be a series of visit types that will not include things like certain diagnosis codes, acute fracture, acute wound, something like that, that probably needs hands-on evaluation or visual assessment. But the other visits will be included. So there'll probably be an exclusion type of either diagnosis codes or vision or visit types that will not be included in telehealth, but they'll be largely the minority, especially in the primary care space. That I think is almost a given. Number two, in the second path is, although the current congressional mandate is 150 days status post the conclusion of the public health emergency, so 150 days after the May 12th timeline, the parity must remain in effect. There is pretty good agreement amongst both parties, and actually some traction in the spending bill that's forthcoming, that there may be a permanent fix to the parity issue for telehealth. So if they do that and CMS mandates it, then the payers will have to follow suit. So I think there are two very strong fixes that will likely resolve this. Obviously, we've got about 6 months of time frame now to let this unfold. But we've been having this conversation for a very long time. And I think everybody, especially from the MVP and Excelis world, agree that we can't go back to where we were, that telehealth is here to stay. It's not only a necessary tool, it's an expectation of the patient population. And to try to unwind that would actually be just fool's play at this point.
Yeah, I would say that, pre-pandemic, there was a lot of traction going with telehealth and where it was going and how they were going to unfold it. The pandemic just allowed it to unfold, right? And it allowed it to show that it can work. And so now it's a question, where do we put the rules and regulations in place? So.
Yeah.
Good. Anyway, well, thank you everybody for that. And please feel free to speak up with any sort of, advice on this topic.
Actually, I'm going to take this Mary Lou Gleason. So this has actually become a very hot button discussion about basically covering MyChart messages or electronic interactions with patients. And there are a couple of large health systems that have taken this on recently. And it's a double-edged sword. So, there is a almost universal pushback amongst patient groups for this, for all the reasons we know. The payers don't really know how to assess MyChart message, EMR exchange. So I think there's a lot of conversation about this. I think this may get resolved if there is some type of permanent telehealth language in the spending bill, where this type of telehealth engagement will be included in that. But even the facilities, I'm trying to remember the large one that did it. Was it Cleveland Clinic? I think it was Cleveland Clinic that did it and then almost immediately backed away and kind of downgraded their plans because they were going to go across the board with billing all MyChart messaging. So it's not all it's cracked up to be. There's a lot to it. So I think it is definitely on the docket, but there's some nuance to it that we'll have to consider for sure.
And there was an article in New England Journal about it too, I believe, within the last few months, again, showing the pros and cons and that there were some cons to it as well, to that billing piece of things.
Right. But no doubt it's become a huge suck of, especially primary care providers' time.
Right.
It's the unaccounted for hours of the day that no one reimburses, and that patients are largely unattentive to the fact that, we're not just sitting around all day answering these messages.
Right. One quick solution for that we've seen in the office for those, especially when they're looking for a medication, is just to quickly convert it to a telephonic visit or to a telemedicine visit, and just immediately respond to that. Why don't we set up a visit to discuss this? And then you switch it to that telemedicine, telephonic visit pretty fast.
Yeah.
Okay, this kind of falls into the next topic, which is these clinical practice topics that I wanted to talk about. We started discussing, how can we improve our overall happiness with primary care, and how can we facilitate referrals to both specialists, and then also make sure that we're sending the right patient to specialists at the right time. And our grand rounds that we started with in October kind of started that conversation, right? That we see that the specialists have processes in place, you know, for example, in GI, that if you have a question about hepatology, you can send an e-consult, you know, through Epic, or you can send an email to a provider, and you can get an answer to your question or an idea if this person needs to be seen fast, not fast, or what the next step of care would be pretty easily. Same thing with pulmonary nodules, that we can get a quick assessment of pulmonary nodules, whether or not they need to be seen or not seen. And for us, it's not only good that we have our education enhanced by these models, because then we start learning through more and more contact of what the things are, what are important, what are important to follow up with. But as well, we decompress the specialist from a visit that they may not have needed to see, and then be able to see another patient who really needed their time. And so I think we need to kind of move in this space a little bit more and see how we can maybe call it disruption of medicine. How can we use our electronic resources? How can we use our colleagues in a positive way to enhance our knowledge, but again, enhance patient care as well? And so there's many models where, again, if the patient has to see somebody twice for the same diagnosis of specialist because they went a little early, that's 2 copays on the patient as well. So is there a way to decompress that from the patient perspective as well? And I would like to kind of propose that we come up with best practices in some of these spaces in order to you know, help patient care, because at the end of the day, we want the best what's of the patient and not overtax them with visits as well. So moving forward, maybe using grand rounds a little bit to look at chronic kidney disease, or look at, you know, osteoporosis, and find what are the best ways of dealing with these diagnoses in terms of both patient care and care delivery. And so again, if people have any suggestions in terms of that space, I think it would be, you know, helpful again for me to hear about that. You know, one quick way that I'll share an experience that I've been doing is with urology. When I have a patient who I feel a new prostate nodule, or they've gotten a PSA which is elevated, you know, I email a particular urologist and say, hey, listen, this is happening. Can you put in this specialized prostate test in the computer for the patient to get this lab test done? And that test is what drives the urologist to decide, okay, this person needs to be seen, this person doesn't need to be seen, or this person needs an MRI, this person doesn't need an MRI of their prostate. And by doing that one test outpatient, that eliminates one visit for the patient and immediately puts them in a track of, you don't have to worry about this PSA, you do have to worry about this PSA. And so if we can come up with a model, maybe with urology or maybe with another subspecialty, to kind of benefit, you know, this patient interaction, I think we should go ahead and try to move with that. And again, decompress our need for referrals, our secretaries to call specialists, or for patients to call specialists. So if anybody has any opinions about that, I would gladly entertain them.
It would be, Valerie Newman here. It would be another thing that would be really helpful would be to work to the referral templates. They're wildly cumbersome, and a lot of times they don't get patients kind of directed in the right place. It would be nice if we could, you know, both with referrals and with radiology, sort of say, this is my clinical question, this is my clinical concern. You know, they've got the chart they can review, route this appropriately, because a lot of times they'll be like, well, okay, I know you ordered this test, but we kind of would like this test, but it goes around so slowly. It takes a lot of work. You're trying to get approval for one thing, then you have to get another test. A lot of times the radiologist will sometimes say, well, we know there's a different way to order this so that you get the right things done. I'm like, well, okay, great. Can you change it? And they're like, no, you have to put a new order in. Why? Well, I mean, we're the clinicians. We're saying this, you know, I don't know how they're necessarily doing some of their sequences. And a lot of times it's just, it's so infuriating, because, you know, we used to have a blank space where we could write in what we needed to have done when it wasn't a standard test. And now it's like, well, if you can't find the right box, then you have these algorithms that come up, say, are you sure? And, you know, why this pulmonary nodule, you know, and on and on. So it would be really nice if we could fast track both referrals and radiology, just to be simpler and kinder and smarter, you know, for this, you know, same thing, GI, where it's like, okay, you know, if I don't say Dr. Call for a particular hepatology issue, it goes to the wrong person over. And I'm like, but it's the GI group with hepatology. No, it's not. It's, you know, so I think having some efficiency there, working to make it efficient from a primary care standpoint would be unbelievably helpful, at least from my perspective.
I think that
And
was a great suggestion.
And I'll make one more comment, which is we should be able to do a word, like if we referral to such and such a name, and then it auto fills. Because the number of times I'm like, oh, this person, are they internal? Are they external? Why is it not matching? Come on, we have a computer system. We've got a name. It should say, okay, do you mean this orthopedic surgeon, or do you mean this GI person? It's crazy to have a hunted, like, well, maybe they're not, maybe they're in geriatrics, no, maybe they're in behavioral. You know, we're trying to figure out which little category, otherwise we won't be able to locate them. And it's such a waste of time for some of those referrals.
And Valerie, I will say U of R is piloting, it's actually going to start, I think actually next month. This enhanced referral is going to start rolling out by service lines. I think it goes across the entire system by July or June or July. That like if you say, hey, I want my patient to be seen in Monroe County, you know, it'll automatically default off the things that don't apply. Or if you say, I want my patient to see Dr. Paul, it's going to default off the buttons that are automatically don't apply because he doesn't see patients there, kind of thing. So it streamlines the answers based on the pre-selected things that go along with the one thing that you already chose.
And that's in Epic, Chad?
That's in Epic. Yeah.
Okay. So again, we have to think about the people that don't have Epic, right? And the people, the other EMR systems. So again, we want that referral to be streamlined for everybody.
Yep, totally agree.
But Valerie, that was a good point about radiology. We'll see if we can work in that space. And I see that Mary Lou is talking about the same thing. You know, again, radiology, when they want to make a specific test change with or without contrast, again, it should be seamless, right? The only thing I would say to that, Dr. Gleason, is that sometimes it's a different code that needs to be approved. So when you actually ask for the prior authorization, the last 5 digits are the actual code of the test. And so contrast and no contrast is different 5 codes.
Actually, what I'm referencing is when you do a test and then they come back and they want another test done, and you know they don't specify it. So when I try to put in the test that they wanted me to get, but I don't know about it takes 2 seconds for them to include that in their dictation. I don't know.
Their dictation, so be more specific.
Yeah, yeah, that would be helpful. This is not exactly, but you know, while we're all complaining, the labs in the computer for clinic collect and lab collect for sputums and urines. I had a patient on Friday. I ordered a flu panel. I ordered a COVID panel. Flu panel got done, no problem. COVID panel, they did not do because they said it said lab collect and it should have been clinic collect. I'm not sure why that appears at all in EMR. It shouldn't make a difference. We're ordering a sputum. Who cares who does it? I don't know if that's something for this group, and I apologize if it's not. I'm new to the group, but I just wanted to throw that as one of the frustrations for primary care. I don't know.
So
I think anything that frustrates us, I think, should be part of this committee because we're trying to enhance our practice.
Okay.
And I don't know I'm going to get this wrong. So I believe, and I'll apologize for this later if I'm getting it wrong, depending on how you collected the sample. So if you did a swab and you send it with a, you know, kind of a wood shafted Q-tip, they could run the flu panel on that, but the COVID has to be a monofilament microfiber, and so it cannot be an organic fiber. So if you sent it, they would cancel it because the swab was not obtained with the appropriate swab type.
Well, this was they were able to, because I called and I had them added on. It's the same swab that we use. It's the same swab.
Okay.
No, it's been a problem, and I don't know if that's just at the Highland Collection Station or what. I don't think they can see it, or there's some issue, but it's.
Yeah.
I have to say there were four providers in our office group complaining about the same thing on Friday afternoon. So it's clearly more than me that has this issue.
It's a universal Epic issue.
Yeah.
Absolutely.
Yeah,
I think it actually has something to do with the fact, unfortunately, that for many reasons that I don't understand, the lab is actually not on Epic. So
Yeah.
it's some strange, it has something to do with that. It's incredibly frustrating. I agree. We probably get 15 to 20 a year where you click the, you didn't click the right button and they don't run the test, and it's incredibly infuriating for patients. And doctors.
Everybody. The last piece is the allergy, immunology, rheumatology group, enrolled or was unrolling prior to COVID a potential penicillin allergy testing protocol with the PCN, and it kind of got derailed with COVID. And their own practice kind of slowed down a little bit during that time as well, but they've begun to start ramping it up. And, with the amount of penicillin allergies that exist, they don't feel that they're going to have the capacity. If we all decide to refer every single one of our penicillin allergic people to it, would they be able to fit these people in, within the next X amount of time? And so as one of my questions to them was, well, is this something that can be done in the primary care office? And the answer was yes. So most of these people, it can be an oral challenge, and it's just a question of time and location, whether you can have someone sit in a waiting room for a certain amount of time after being given a dose of penicillin. So this is another, potential money-making opportunity for primary care to kind of participate in this ability to take out penicillin allergies from our allergy list, since there's such a large amount of people that are really truly not penicillin allergic. So I think if people are interested in having this, I could have the allergy group present to us one day of how to do this, and really show the do's and don'ts of how to go ahead and unroll this in our practices, because we all probably have time and space where we could potentially do 2, 3, 4 a week, 5 a week, and benefit the patients and benefit society in general if we're taking away an allergy that potentially makes us use less broad spectrum antibiotics. So if anyone's interested, are people interested in hearing about this?
It was intentionally a pretty benign and short thing. Like, it's not hard to do.
Yeah, it's a question of time, really. You get it based on your concept that you just had a rash. You're going to take a certain dose of penicillin or amoxicillin, and then it's just a question of time of watching and waiting. And then based on that, you're cleared or not cleared.
And being prepared in the very rare case to respond to
a
reaction. Right.
A reaction, exactly. And the only people that really do not participate is anybody who had a more significant reaction than rash, right? So anaphylaxis, significant vesicular disease, things like that are people that don't get allergy tested. It's not in our office for sure, but usually don't get tested in general. Well, Dr. Gleason said that it sounded great, so I'm going to say that that's a yes. So we're going to go with, maybe we'll have them present in our committee.
Filmmaker wants in too, so that's a good thing.
So Phil did too.
Oh, good. So we're in. So two votes is a majority as far as I'm concerned.
That's right.
Great. If anybody has ideas for grand rounds, again, applicable to primary care and how to enhance our ability to do things, please feel free to reach out to me or Renee. We'll be happy to entertain those ideas. I'm looking into chronic kidney disease and maybe osteoporosis as two potential other topics that we can have soon in grand rounds. Renee, anything else from your side?
I would just add on to that topic about grand rounds is the consideration of this group about how do we get the information from grand rounds to providers who didn't attend. We had some great presentations of people who attended the last grand rounds, learned how to do a better liver workup, learned how to do a better lipid management. How do we distill that content into resources that are accessible and useful? Not everyone wants to watch a YouTube video. So, but we're creating good content. We are creating what amounts to clinical decision support. How do we get that to the whole network? What does that look like? Folks' thoughts on that. Nothing we're going to solve tonight, I'm sure, but just something to add to your contemplation of educational, clinical education opportunities. Thanks, Diego.
Yeah. Steve, any topics you have that No?
I'll give it some thought. I'll give it some thought. I think this CKD topic is great. Especially around using some of the new GFR calculations, the cystatin and all of that. I think there's some really good stuff that can save us sending patients to the nephrologist.
Absolutely.
Our pharmacy staff recommends we just send out any clinical education out under the Pharmacy Pearls header, and it'll be, you know, a slam dunk that people will read it. So they're just showing off that people like their content.
Well, that would, you know, speaking of pharmacy, I guess that would be, I don't know if what the group thinks, but obviously continuous glucose monitoring becoming more and more a part of our lives and our patients' lives. I don't know if that might be a topic that would be beneficial for people to hear about, a little more education around that.
Yeah, I wish it was covered better than it is by the insurance companies. I mean, that's part of the biggest
I know.
downside is that they haven't really embraced it. And, you know, this insulin requirement in order to really be able to get a CGM is, you know, detrimental, whereas most people would wear the CGM and give us data that would be invaluable to us.
So maybe bang for your buck, since it's not, maybe that's not a great topic, just since.
No, I think
not
it's a
everybody-
great topic for me to be aware of, and I think this may be part of that whole reimbursement topic that LG is working on, because that is maybe where we have to advocate for something like that, because again, that's part of our making our life easier as well as our patient's life, right? We have to be patient-centric, right? And so the CGM is a patient-centric device.
Diego, one more thing. What about sort of enhanced lipid measurements like lipoprotein A, CRP, ApoB? I mean, I'm using it a lot for risk stratification. It's relatively low cost and provides a lot of benefit. So I wonder if we want to maybe talk about something like that.
Okay, that's a good one to write down. Perfect. Good. Well, if no one has any other topics, Renee, I think we went through our agenda. I thank everyone very much for participating tonight, and we'll see you again in a couple months.
April 27th is our next meeting.
April 27th. Thank you. And we owe Chad 30 seconds.
Go, Chad, knock yourself out.
I'm just gonna scream trauma, trauma, trauma.
I'm gonna give you trauma.
Let me tell you.
Oh, my heavens. Oh, hopeless.
Poor taste.
Thank you,
Peter, poor
everybody.
taste.
Very poor taste.
Have a good
Good
night,
night.
guys.
Bye, everybody.